Pulmonary disease encompasses a wide spectrum of conditions that affect the respiratory system, from acute infections to chronic disorders that progressively impair lung function. Now, these diseases can impact both the upper airways, which are responsible for filtering and humidifying the air, and the lower airways and lungs, which handle gas exchange. Pulmonary conditions are typically categorized based on their underlying pathophysiology. Obstructive diseases, like chronic obstructive pulmonary disease and asthma, involve airflow limitation due to airway narrowing or obstruction. These conditions increase airway resistance, making exhalation difficult and leading to air trapping and hyperinflation. Restrictive diseases, such as pulmonary fibrosis and interstitial lung disease, are characterized by stiffened lung tissue that limits lung expansion and reduces the total volume of air the lungs can hold. Infectious diseases, including pneumonia and tuberculosis, are caused by pathogens that inflame and damage lung tissue, impairing gas exchange. Vascular diseases, such as pulmonary embolism and pulmonary hypertension, affect the pulmonary blood vessels, which disrupts oxygen delivery to systemic tissues. Traumatic conditions like pneumothorax or hemothorax can result from physical injury to the chest, leading to complications such as lung collapse or fluid accumulation in the pleural space. We'll spend some time reviewing some of these specific cases of disease that can help develop the pulmonary. We'll spend some time reviewing some We'll spend some time reviewing some specific cases of disease that can develop in the pulmonary system, which can help develop our understanding of how to treat lung disease. Foreign body obstruction in the upper airway is an emergency that can quickly progress to complete airway blockage and respiratory arrest. Foreign bodies can become lodged at any point along the upper airway, from the nasal cavity to the trachea, with consequences that depend on the object's size, shape, and location. When a foreign object blocks the airway, it disrupts the normal flow of air to and from the lungs. Obstructions in the pharynx or larynx are particularly critical because these areas are narrower and more vulnerable to complete occlusion. Prompt recognition and rapid intervention are essential to preventing life-threatening complications. Foreign body obstructions can be classified as either partial or complete. In a partial obstruction, the object blocks the airway but still allows some air to pass through. However, the airflow is turbulent and less efficient, often requiring greater respiratory effort. Patients with partial obstructions may exhibit stridor if the obstruction is higher in the airway, or wheezing if it's down lower. A complete obstruction, on the other hand, prevents any airflow, leading to hypoxemia, loss of consciousness, and potentially cardiac arrest within minutes if the issue is not resolved. While the body's natural response is to cough reflexively to expel the object, this mechanism can fail if the foreign body becomes tightly lodged or if the individual cannot generate an effective cough. Swelling or airway spasm around the obstruction can further worsen the situation, increasing the urgency of intervention. Certain populations are more prone to foreign body obstruction. Young children, especially those under 5, are at the highest risk. Their airways are narrower, and their natural tendency to explore objects orally puts them in danger. Neurological impairments, such as those seen in patients with neuromuscular disorders, also increases the risk of affecting swallowing or muscle coordination. Eating habits, like talking, laughing, and moving around while eating, can lead to accidental aspiration of food or other objects. And finally, specific types of objects are frequently involved, such as small toys, food items like nuts or grapes, and coins. Awareness of these risks can help guide both prevention and timely intervention of foreign body obstruction. Management of foreign body obstruction depends on the degree of airway compromise, with prompt intervention being critical, especially for complete obstructions. For a partial obstruction, if the patient can still cough and breathe, they should be encouraged to continue coughing to try and expel the object. Close monitoring is important, as a partial obstruction can quickly become complete if the foreign body shifts or swelling develops. Rapid transport to a healthcare facility is strongly advised. In cases of complete obstruction in conscious patients, the approach varies by age. For adults and children over 1 year old, abdominal thrusts are the preferred method. Abdominal thrusts generate enough force to dislodge the object, but should be performed carefully in young children or frail individuals to avoid injury. If the patient is pregnant or obese to the point that you cannot encircle their abdomen, adjust the positioning of your hands to perform chest thrusts in lieu of abdominal thrusts. For infants under 1 year old, a combination of 5 back blows and 5 chest thrusts is recommended. The infant should be held face down with their head lower than the chest to allow gravity to assist in expelling the foreign object.
It's a terrifying moment as a dad having a meal with his son starts choking. Todd Hendricks and his 6-year-old son Anthony were eating boneless chicken wings when it happened. Todd took a bite and it went down the wrong way.
I was reaching for my drink and I swallowed again. And I was like, that's not good.
So what did that feel like?
Like you can't breathe real fast.
His little boy wasn't sure what was going on and continued eating.
It's scary. You're looking at your kid, you choke, you're blacking out. That's not fun.
Look what happened next. The guy sitting with his son at the next table sees something is wrong and jumps into action. Immediately, he performs the Heimlich maneuver. And if you think he knew just what to do, you're right. He's an off-duty New Jersey state trooper.
As soon as I heard the pound on the table, what I thought was, because I heard silverware shake, I just kind of looked back. And as soon as I looked back, I could see he was fully red.
How are you coming, man? How you feeling?
We reunited Todd and Trooper Dennis Pillay today at the Buffalo Wild Wings restaurant where it all happened. They showed us how the life or death struggle unfolded.
I came behind him. His hands were already up around his neck, which made it real easy for me to get underneath and behind.
Give us a step-by-step of how to perform the Heimlich maneuver.
I'm going to come around. I'm going to make a ball with my fist, the other hand, but first I'm going to feel where your solar plex is. I'm going to get right underneath it and push.
And then you're going to make thrusts going up, and it's going to push.
You'll feel I don't know if you felt it, you'll feel the air.
Right.
So you push hard enough, it's going to dislodge anything that's in there.
Youthful information we all need to know in case you don't have a hero trooper at the next table.
If the patient becomes unconscious, immediate CPR is necessary, focusing on chest compressions to generate positive pressure that may dislodge the object. Rescue breaths should only be attempted if the airway appears clear. For visible obstructions, direct laryngoscopy can help visualize and remove the object using tools like the McGill forceps. In extreme cases, when standard technique fails, an emergency cricothyrotomy may be required to bypass the obstruction and restore airflow. Do not exceed the scope of your individual level of practice, and always follow your local protocol. COPD, or chronic obstructive pulmonary disease, is a progressive condition characterized by persistent airflow limitation and chronic symptoms, including shortness of breath, chronic cough, and sputum production. It's a major global health issue and one of the leading causes of morbidity and mortality, particularly in individuals over the age of 40. Smoking is the most significant risk factor, but other contributors include exposure to environmental pollutants, such as industrial chemicals or biomass fuels, and genetic factors. The pathophysiology of COPD is driven by chronic inflammation triggered by smoking or environmental exposures. Inflammatory cells release proteases, such as elastase, which breaks down connective tissue and damages the lungs. Two primary processes contribute to the disease: emphysema, where the destruction of alveolar walls leads to reduced surface area for gas exchange, which causes air trapping and lung hyperinflation, and chronic bronchitis, which is characterized by mucus hypersecretion and thickened bronchial walls, which increase airway resistance and obstruct airflow. Both of these changes impair expiration, which increases the work of breathing and reduces overall lung function. Clinical presentation of COPD varies by stage. In early disease, patients may have dyspnea or a cough that worsens with exertion. In advanced stages, symptoms progress to a persistent productive cough, wheezing, and a severe shortness of breath. Exacerbations, often triggered by infections or environmental factors, lead to worsened respiratory symptoms requiring additional treatment. Chronic hypoxemia and hypercapnia from COPD can cause complications like pulmonary hypertension and right-sided heart failure, while systemic effects include weight loss, muscle wasting, and psychological impacts like anxiety and depression. Managing COPD involves a comprehensive approach tailored to the patient's needs. Smoking cessation is the most effective way to slow disease progression and should be prioritized. Pharmacological treatments include bronchodilators. Medications that are either long-acting beta agonists or muscarinic antagonists are preferred for maintenance therapy, while inhaled corticosteroids are added for patients with frequent exacerbations. Non-pharmacological interventions are equally vital. Pulmonary rehabilitation, which includes exercise training, education, and nutritional counseling, improves exercise tolerance and quality of life. Long-term oxygen therapy is recommended for patients with severe hypoxemia and can improve survival in selected cases. For advanced COPD, options like lung volume reduction surgery, lung transplantation, or endobronchial valves can be considered for patients meeting specific criteria. Asthma is a chronic inflammatory condition of the airways characterized by reversible airflow obstruction, as well as bronchial hyperresponsiveness and inflammation. It affects individuals of all ages, often beginning in childhood or adolescence, but it can develop at any age. Some common triggers include allergens, exercise, respiratory infections, air pollution, and occupational exposures. Asthma manifests as recurrent episodes of wheezing, shortness of breath, chest tightness, and cough, often varying in intensity and frequency. The pathophysiology of asthma revolves around chronic airway inflammation triggered by allergens or respiratory irritants. Immune cells release inflammatory mediators like histamine, leukotrienes, and cytokines, leading to bronchoconstriction, increased mucus secretion, and airway edema. Over time, persistent inflammation can lead to airway remodeling, characterized by thickened airway walls and increased smooth muscle mass. These changes reduce the reversibility of airflow obstruction, particularly in poorly managed asthma. Asthma symptoms are typically episodic, with patients experiencing wheezing, shortness of breath, chest tightness, and cough, often worsening at night or early in the morning. Severe exacerbations, such as status asthmaticus, are life-threatening episodes of persistent respiratory distress that require immediate and aggressive treatment. Diagnosis is based on clinical history, symptom patterns, and pulmonary function tests. Spirometry demonstrates reversible airflow limitation, defined by an increase in FEV1 of at least 12% after bronchodilator administration. Bronchoprovocation testing uses agents like methacholine and assesses airway hyperresponsiveness in a controlled setting. Managing asthma involves both acute treatments for symptom relief and long-term therapies to prevent exacerbations. For acute episodes, short-acting beta agonists like albuterol provide rapid bronchodilation to relieve bronchoconstriction. Maintenance therapies include inhaled corticosteroids as the cornerstone of treatment to reduce inflammation. For moderate to severe asthma, long-acting beta agonists, or LABAs, are added to provide extended symptom relief. Advanced therapies, such as biologics, which target specific inflammatory pathways, are used in patients with severe or poorly controlled asthma. Non-pharmacological strategies include patient education on inhaler techniques, personalized asthma action plans, and trigger avoidance. Vaccination against influenza and pneumococcus is critical to prevent infections that could potentially worsen asthma. Pneumonia is an acute infection of the lung parenchyma that involves inflammation of the alveoli and interstitial tissues. It is caused by a range of pathogens, including bacteria, viruses, fungi, and occasionally parasites. Certain populations, like the elderly or immunocompromised individuals, and those with chronic conditions such as COPD or heart disease, are particularly vulnerable to pneumonia. Pneumonia is classified into community-acquired pneumonia, which occurs in individuals outside of healthcare settings, hospital-acquired pneumonia, which develops in hospitalized patients, and ventilator-associated pneumonia, which occurs in mechanically ventilated patients. The pathophysiology of pneumonia begins when pathogens invade the lower respiratory tract, bypassing the lung's natural defenses like mucociliary clearance and alveolar macrophages. This triggers an immune response, leading to inflammation and the accumulation of fluid, pus, and cellular debris in the alveoli, a process known as consolidation. This impairs gas exchange, causing hypoxemia. Systemic symptoms such as fevers, chills, and malaise result from the release of inflammatory mediators during the infection. Patients with pneumonia commonly present with a fever, productive cough with purulent or blood-streaked sputum, pleuritic chest pain, and varying degrees of dyspnea. Severe cases may exhibit signs of respiratory distress, including tachypnea, accessory muscle use, and cyanosis. Pre-hospital providers should be particularly alert to atypical presentations in elderly patients, such as confusion or altered mental status, which may be the only signs of infection. During assessment, inquire about recent illness, sick contacts, travel history, and underlying conditions like COPD or diabetes that could potentially increase susceptibility to pneumonia. Pre-hospital management of pneumonia focuses on stabilizing the patient and addressing hypoxemia and respiratory distress. Oxygen therapy is the cornerstone of care, aiming to maintain an SpO2 above 92%. In cases of severe hypoxemia or distress, CPAP may be considered to improve oxygenation by recruiting alveoli and reducing the work of breathing. Sepsis management involves recognizing signs like fever, tachycardia, hypotension, and altered mental status. IV fluid resuscitation with crystalloids may be needed to stabilize hemodynamics. For patients in respiratory failure, advanced airway management, including intubation, should be considered based on protocols, along with rapid transport to a facility equipped for escalation of care. Acute bronchitis is a common respiratory condition characterized by inflammation of the bronchi, leading to persistent cough and mucus production. It is most often caused by viral infections, though bacterial infections and irritants like smoke or pollution can also contribute. Differentiating acute bronchitis from other conditions such as pneumonia or asthma exacerbations is important, especially in patients with underlying respiratory diseases like COPD. The pathophysiology of acute bronchitis involves inflammation of the bronchi, leading to increased mucus production, bronchial wall swelling, and sometimes bronchospasm. Now, these changes result in symptoms like cough, which can be productive, wheezing, and mild shortness of breath. Patients typically present with a persistent cough lasting several days to weeks, along with chest discomfort and sometimes a low-grade fever. In patients with underlying respiratory conditions, symptoms may be more severe and they may require close monitoring and intervention. Assessment is important in pre-hospital care for acute bronchitis. Gather a focused history, including any duration of cough, recent sick contacts, and any underlying respiratory or cardiac conditions. Evaluate for signs of more severe conditions such as high fever, pleuritic chest pain, or a green or blood-streaked sputum, which may indicate pneumonia or other serious illness. Implement strict infection control measures, including wearing the appropriate PPE and placing a surgical mask on the patient to minimize droplet spread. During transport, closely monitor the patient's respiratory rate, oxygen saturation, and signs of distress to guide further care and ensure the receiving facility is prepared for the patient's needs. Pulmonary embolism is a life-threatening condition where one or more pulmonary arteries are suddenly blocked, most often by a blood clot that has traveled from the deep veins of the legs, a condition known as deep vein thrombosis. The blockage causes a ventilation-perfusion mismatch, as blood flow is obstructed in well-ventilated alveoli, which impairs oxygenation. In severe cases, increased pulmonary vascular resistance leads to right ventricular strain and progress to shock or cardiac arrest. PE is classified based on severity. A massive PE, where the patient exhibits hemodynamic instability, and submassive PE, with significant symptoms but no immediate signs of shock. The clinical presentation of PE varies widely, but often includes sudden onset of dyspnea, pleuritic chest pain, and tachypnea. Some patients may also report cough or hemoptysis. Pre-hospital providers should assess for signs of DVT, such as unilateral leg swelling, warmth, and tenderness, as these indicate an increased risk of PE. In severe cases, PE can cause hypotension, altered mental status, and other signs of shock. The most critical complication is cardiac arrest, which often presents as pulseless electrical activity. Acute respiratory distress syndrome, or ARDS, is a severe life-threatening condition caused by widespread inflammation and damage to the alveolar capillary membrane. It results in non-cardiogenic pulmonary edema and profound hypoxemia, which is often resistant to standard oxygen therapy. Common causes of ARDS include sepsis, trauma, pneumonia, aspiration, and massive transfusion. The pathophysiology involves increased capillary permeability, allowing fluid to flood the alveoli, disrupted surfactant function, which leads to alveolar collapse and reduced lung compliance, and a ventilation-perfusion mismatch, which severely impairs oxygenation. Patients with ARDS typically present with severe dyspnea, tachypnea, and cyanosis, often accompanied by hypoxemia that does not improve with conventional oxygen therapy. Other signs include tachycardia, use of accessory muscles for breathing, nasal flaring, and in severe cases, altered mental status due to hypoxemia. On auscultation, you may hear fine crackles, especially in the lower lung fields. The onset of ARDS is usually rapid, occurring within 6 to 72 hours of a triggering event such as sepsis, trauma, or aspiration. Pneumothorax is a condition where air enters the pleural space, causing the lung to partially or fully collapse. It can occur spontaneously, either as a primary pneumothorax in otherwise healthy individuals, often tall, thin males, or as a secondary pneumothorax in patients with underlying lung disease like COPD. Traumatic pneumothorax results from chest injuries such as rib fractures or penetrating trauma, while iatrogenic pneumothorax can follow medical procedures like central line placement. A tension pneumothorax is the most severe form, where trapped air compresses the lungs, heart, and blood vessels, leading to cardiovascular collapse and requiring immediate intervention. The pathophysiology of pneumothorax involves the loss of a negative pleural pressure, causing the lung to collapse. In a tension pneumothorax, air enters the pleural space with each breath but cannot escape, leading to progressive intrathoracic pressure that compresses the lung and cardiovascular structures. Patients often present with sudden pleuritic chest pain and dyspnea, along with decreased or absent breath sounds on the affected side. In severe cases, tension pneumothorax may cause jugular venous distension, hypotension, and tracheal deviation away from the affected side, though tracheal deviation is typically a late sign. Hemothorax is a condition where blood accumulates in the pleural space, compressing the lung and causing respiratory compromise. The most common cause is trauma, such as rib fractures or penetrating injuries. Non-traumatic causes, though less common, include malignancy, vascular rupture, or clotting disorders. The primary complications of hemothorax are impaired oxygenation due to lung compression and hypovolemic shock caused by significant blood loss into the pleural cavity. The pathophysiology of hemothorax involves blood accumulating in the pleural space, compressing the lung and reducing its ability to expand. This leads to ventilation-perfusion mismatch, causing hypoxia. Significant bleeding into the pleural space can also result in hypovolemic shock as blood loss reduces circulating volume. Patients often present with chest pain, dyspnea, and tachypnea. On examination, you may find absent breath sounds and dullness to percussion on the affected side. In severe cases, patients may show signs of hypotension, tachycardia, and altered mental status. During assessment, identify the mechanism of injury, such as blunt or penetrating trauma, and ask about anticoagulant use, which increases bleeding risk. Monitor for signs of shock, including hypotension, tachycardia, and diaphoresis. Position the patient in a semi-Fowler's or upright position if it's safe to improve lung expansion and ease breathing. Maintain strict infection control practices, including PPE, especially when managing open wounds or bodily fluids. Continuously monitor oxygen saturation, respiratory rate, and blood pressure, and communicate any signs of deterioration to the receiving facility. Pleuritis, also called pleurisy, is the inflammation of the pleura, the membrane surrounding the lungs. It causes sharp chest pain that worsens with breathing, coughing, or movement. Pleural effusion, on the other hand, refers to accumulation of fluid in the pleural space, which can compress the lung and impair breathing. The causes of pleuritis and pleural effusion vary. Pleuritis is often linked to infections, such as pneumonia, autoimmune conditions like lupus, or a pulmonary embolism. Pleural effusion can result from heart failure, infections, malignancy, or trauma. Understanding these distinctions is important for identifying the underlying cause and managing symptoms effectively. The clinical signs of pleuritis include sharp, localized chest pain, which worsens with deep breathing, coughing, or movement. Symptoms often accompany the underlying condition, such as fever and infections or productive cough and pneumonia. Patients with pleural effusion frequently experience shortness of breath and chest discomfort, especially when lying flat. On examination, breath sounds are often reduced or absent over the effusion, and percussion reveals dullness in the affected area. Severe cases may present with tachypnea, hypoxemia, and other signs of respiratory distress. Lung cancer is the leading cause of cancer-related deaths globally, largely due to late detection and its aggressive nature. It's categorized into two primary types: small cell lung cancer, which grows and spreads rapidly, and non-small cell lung cancer, which progresses more slowly but is more common. Patients often present with complications like pleural effusion, respiratory distress, or hemoptysis. Advanced stages may involve metastasis to other organs, causing systemic symptoms such as bone pain or neurological deficits. The pathophysiology of lung cancer begins with genetic mutations that lead to uncontrolled cell growth in the lung tissue. As tumors grow, they can obstruct airways, compress nearby structures, or invade the pleura, causing significant respiratory symptoms. Lung cancer can spread through the lymphatic system or the bloodstream, leading to metastasis in the brain, bones, liver, or adrenal glands. Additionally, some lung cancers can cause paraneoplastic syndromes due to tumor-secreted substances, leading to metabolic issues like hypercalcemia or hyponatremia, which may present as confusion, weakness, or seizures. Patients with lung cancer commonly experience chronic cough, shortness of breath, chest pain, hemoptysis, and unintentional weight loss. In advanced stages, acute complications can arise, such as respiratory distress from airway obstruction or pleural effusion. Significant hemoptysis may occur if the tumor erodes into blood vessels. Metastasis can cause additional symptoms like bone pain, seizures, or jaundice, depending on the affected organ. Occupational lung diseases result from prolonged exposure to harmful substances in the workplace. Pneumoconiosis involves chronic inflammation from inorganic dust, leading to lung fibrosis and restrictive breathing. Hypersensitivity pneumonitis results from repeated allergic inflammation, causing granuloma formation and fibrosis. Toxic inhalation syndromes involve chemical injury to the respiratory lining, which can lead to airway swelling, bronchospasm, and impaired gas exchange. Symptoms differ by disease type. Pneumoconiosis causes chronic respiratory symptoms like dyspnea, cyanosis, and clubbing. Hypersensitivity pneumonitis presents with flu-like symptoms shortly after exposure, including fever and cough, and toxic inhalation syndromes can cause acute symptoms, such as stridor, wheezing, and respiratory distress.